but then I decided to make this as an open platform where knowledge sharing can happen. That is why my decision was taken, so that whatever I know can be transferred to all of you people, so that there will be some advantage with regard to your practice in implants. Now, is it visible and audible for everyone? Can you type or text it? Whether
Yes or no?
yes or no? Okay, we'll just go ahead. Now, my primary intention is that in the first episode, I'll be taking you through the process where we search for the target landmarks in OPG. Now, I'll just tell you the sequence of events which I follow. Primarily, it's usually clinical examination according to the protocol. After that, you go ahead with OPG. Then you take CBCT. Then you do a treatment planning. During the treatment, sometimes I might take an OPG as well, IOPA and CBCT. Post-implant placement, OPG and CBCT. After which, the crown and bridge placement and occlusal correction and follow-up. These are the sequence of events which usually we follow. But nowadays, since most of the patients are from NRIs or from abroad or from a distant place, they send us the OPG and you have to do a treatment planning according to the OPG. So this is one of the biggest challenges. So most often, after seeing the OPG, you will have to do a treatment planning, come to the financials, and then advise them with regard to what is your plan as well as the cost of the treatment. So only after that, most of the times we get to see the patient clinically. So this is a big problem, but still you can overcome this problem. Now, talking about evaluation of OPG, the first thing what you should understand is, as far as OPG is concerned, you can have a broad idea about the whole thing, but there is no specificity for it. For example, the reason behind that is, it is a panoramic radiograph, one thing. There will be a lot of shadowing, in the sense there is a lot of horizontal overlapping. That's one thing. And by using this OPG, you will not be able to find out the exact prognosis of the tooth, of a tooth. Like, say for example, upper or lower anteriors. You can never identify whether the tooth has got a good bone support, what is the condition of the tooth, because of the cervical spine, which gets superseded, or rather it gets overlapped. So because of that reason, the anteriors, you can never come to a conclusion whether the tooth has got a better prognosis or not. The next thing is evaluation of the OPG. You can decide whether the tooth has to go for a segmental or a full mouth. Now, the biggest thing, what I would tell you is, if it is a segmental case, how to correct the plane of occlusion. Most often I have seen a lot of people not correcting the plane of occlusion. Plane of occlusion, I will be talking about the plane of occlusion corrected before any implant procedure. Next is the target areas. Target areas for maxilla and mandible will be covered, but today our topic will be till the target areas in the maxilla. The last will be considering the proximity of inferior neural canal to the placement where the place where the implant has to be placed. Now see, this is a case one, just sharing you this case. When you see this case, you know the upper one is a full mouth. The prognosis of the maxillary tooth are all compromised in this case. For the lower one, you can see on the right side from the first premolar to the left side premolar, the tooth has got a good prognosis. But now your question is whether you should go, see, you can always confirm whether these tooth which is remaining has good prognosis by taking an IOPA rather than deciding from an OPG. Now the question is whether you want to retain this tooth or not. There are few things which will come onto your mind that I will be telling you later on. Now in this condition, upper is a full mouth case. Lower can be segmented on both the posteriors of the left and the right lower tooth. Retaining that first, you can try to retain the teeth from right first premolar to the left second premolar. But there are few things when you decide on this there are few things which has to go through your mind. One is if you are trying to there is something called as cross arch stabilization. Cross arch stabilization means when you try to construct from here till here by using a single frame, you have an arch which is being stabilized cross arch. So this gives more amount of stability. So now your question is whether you prefer a cross arch stabilization to a segmental one. Segmental is from here till here and from here till here. So you should decide on risk versus benefit ratio when you decide on this, whether you have to go for a full mouth or a segmental. And you should give suggestion to the patient. There are a few things which will come on to that. When you if you plan in this case for a lower full mouth, the advantage is cross arch stabilization. And another advantage is even if you are planning for the segmental from here till here, you will have to place 3 implants. From here till here, again you will have to place 3 implants. So total of 6 implants in the lower. And if you are planning for the entire dentition lower, you will have to place 2 more additional, 1 implant here and 1 implant here. So total of 8 implants. So addition of only 2 implants you require for a cross arch stabilization. So next question is, this particular patient has lost almost all his tooth. Whether this remaining tooth will last a lifetime is another question. So you understand? So the decision has to be whether this has to go for a full mouth. Upper definitely has to go for a full mouth. But for the lower, whether you should go for a full mouth implant or not is a question. If you go for a full mouth, the advantage is cross arch stabilization, one thing, which gives more stability for the implants because the load is more distributed equally well among the implants. That is one. Second thing. The third thing is, since the patient has lost most of the teeth, there is a possibility that in the long run, he might lose the remaining tooth also. So you can ask the patient to decide on these circumstances whether to. And as far as economy is concerned, it is more. You just need to place 2 more implants to convert this into a full mouth case. Now this here you can see that this tooth has got a poor prognosis. It has to be removed along with this tooth. So remaining things can be a segmental. You can go for a bridge here. You can do a bridge here also. We decided to remove these 2 implants and place 2 implants here and 2 implants. So this becomes a segmental case. Here also the same way. And here we plan to give a bridge. So this is a segmental case, and this tooth has got a bad prognosis, but this usually I get it confirmed by taking an IOPA. So see how we have rehabilitated this case. You can see that we have placed a pterygoid implant here, we have placed a bridge here, and we have placed 1 pterygoid, and then then 3 more of implants, and then we did the rehabilitation. So those 2 teeth has been removed. These 2 teeth has been removed because it had a very bad prognosis. But it was confirmed by using an IOPA. See, in this case, if you see from the OPG, you can see that these two teeth are quite stable, but they were mobile clinically, and all this bridge was mobile, and these 2 teeth were also mobile. But this area looked stable in OPG, but I confirmed it from IOPA and found that this also had a very bad prognosis. So this was converted into a full mouth case in the upper. On the lower, these 2 teeth from the OPG itself is found to have a bad prognosis. So this also was found to be having a bad prognosis. So we decided to remove this. So the upper was planned as a full mouth because everything had a very bad prognosis, which was confirmed by IOPA on the upper right side, and on the lower right side and the left side, it was also confirmed by IOPA that they had a very bad prognosis. So the treatment plan was made in such a way that these tooth which had a very bad prognosis was removed. You can see 3 implants being placed and the full mouth rehabilitation was done. I hope if you have any doubts, please keep. Can you? I will just answer all your questions towards the last. Can you just tell me what are the questions which were asked?
How do you confirm by IOPA?
One question which has come up is how do I confirm by IOPA? See, as the normal way, whether you because this OPG has no specificity, it is just a broad idea. But taking an IOPA, you can know the prognosis of the tooth based on any large lesions. Even I am a person who treats all large lesions by root canal treatment alone, and I have seen astounding results when I follow it for 6 months. So if you feel that tooth has got a bad prognosis because of the fracture, because of increased amount of periodontal bone loss, so on and so forth, you will decide that this tooth will not have a larger or better prognosis, and then we decide it has to be removed or not. Now in this case, here also you can see that on the lower left side, the prognosis was very bad, so we decided to take it out and then go ahead with segmental case, and we took this as a segmental case in the lower left side, and upper full mouth, it was kept as a full mouth, upper. As I have told you in the previous, when I showed you this OPG, we had discussed, you can tell me if any question comes in. So in this we have decided, I have described in detail, explained in detail, upper will definitely go for full mouth, lower can be segmental, but as far as the expense wise is concerned, the lower, it is preferable that addition to implants, usually in this, if you do a segmental case, see, this area to be rehabilitated, you need 3 implants, and this area you need 3 implants. For immediate loading, I am talking about immediate loading. You need 3 immediate functional loading. You need 3 implants in this side and 3 implants in this side. But if you want the entire, if you want to treat the entire area, you need just 8 implants. That is addition of 2 implants. So economically wise, with the addition of 2 implants, you get a better thing, that is gross
extraction of wisdom tooth is must.
Exactly. One question from Dr. Manu, whether all the wisdom tooth has to be extracted. But in this case, in this particular case, since it was submerged, I did not go ahead with the extraction of the wisdom tooth. I'll talk about that in detail afterwards. But then you see this case. This case was a full mouth because it was pointless to retain this portion. Okay, so I did this upper full mouth and the lower was a segmental case. I did it lower 6 to 6, so the bite was symmetrical. See, my plan is there should not be asymmetry in the bite. This wisdom tooth was kept as such because it was submerged. It was never in the mucosal area. So I did not want to remove that. And from here, from the 6 to 6, and you should always see to that whenever you plan implants or whatever it is, you should always plan for the symmetry in the occlusal plane. That is from here till here, and from here till here, the plane where the chewing surface is should be symmetrical in length. Or else what will happen is the patient might start chewing on the side which has got a greater length. Say if this length is more, patient will feel from here. If you have rehabilitated and you use one more implant and then you have rehabilitated like this. Like this. Now see, if I have placed one more implant here and then I have constructed a plane like this, what will happen is patient will start chewing on this side more than the other side, more than this side. So this will result in instability in the occlusion. There can be overloading in this side and underloading in the other side. So it is prudent that you should keep symmetry of the bite. Both sides, both left and right side should have a symmetry in length. So that is one major thing. Always when you plan, always symmetry of the bite should be.
Eraser.
So now considering the plane of correction, this is called as plane of camphor. This is the line which is drawn parallel from the ala of the nose to the tragus of the ear. So basically, always ensure that the occlusal plane is parallel. Our occlusal plane is parallel to this line. This is called as plane of. This is known as plane of camphor. Okay. So this is actually. Now this is the ala tragus line. You can see the ala of the nose to the tragus. Different position of this line, plane of camphor, has been suggested. Some say that it starts from the upper border of the ala, that is this portion. Some say that it should start from the middle of the tragus. Some say that it should start from here. According to my observation, it varies from people to people, depending upon the length of the mandibular ramus. So you cannot generalize, but you can understand a bit by seeing this. You can see this here it is always from the middle. This is the middle of the tragus till the ala. You can see this occlusal plane usually will be like this, starting from the corner of the lips to the inferior border of the pinna, which also corresponds to the middle line in the ramus region. Ramus will be almost like this. So almost in the middle line, the occlusal plane will come. So this is all arbitrary lines which will help you decide on the plane of occlusion. So this is another thing. You can see this has been drawn like this. So this will be the occlusal plane. Always ensure that this occlusal plane is followed. Now see this implants and then implant will fail. So this plane has to be corrected. Understand? If you keep this, there will be a lot of interferences. If you keep this plane like this, the same way, there will be a lot of interferences, and ultimately there will be interference in the anterior protrusive as well as in the lateral movements, as well as in, both on medial and the lateral movements. So this can result in failure. So primarily, when you are planning for implants in these kind of cases, the first step has to be correcting this plane of camphor or plane of occlusion. Now here you see these two teeth. The plane. No, I will tell you one more thing. If you see the radiograph, you can see. I'll show you another radiograph. See, in this, usually the ala will come near to the condyle. Okay, and this is the area where. Sorry, this is the tragus area, and this is where the ala comes. So you just draw a line arbitrarily like this. Clear? From the radiograph, this is the ala tragus line. Now, you see, I'll just draw here also. So you can see that these two are almost in the same plane. This is very clear, I believe. Now, OPG is when you have your lower jaw opened slightly. So that means you have this mandible, in the lower jaw, this molar will be slightly more anteriorly placed in the OPG. In reality, this will be somewhere here. So you can understand that this plane is a stable plane. That is, now you try to draw. Now you just try to draw like this. Now, once in most retruded position, this tooth will come in contact with this. And this plane, there is no supraeruption at all. So when you draw a line, this will almost be parallel. So this is one way in which you can identify the plane of occlusion. This has to be applicable even for bridges, not only for implants, it has to be applicable for bridges also. If you don't correct this, there will be a lot of stress concentration happening, there will be a lot of interferences in the anterior movement of the jaw, which can result in fracture of the bridge and ultimate failure of the receiver. So I hope this point is very, very clear. Now, see here, this is supraerupted. By trimming off like this, you will be able to gain space for placing implants like this. But that is not enough. You have to get it at the same plane as like this. Sorry. So here I have drawn the same thing. This is the ala tragus line, and this is the occlusal plane. Now see this case. This case has been referred to me, and I had asked them to correct the plane of plane and then send the OPG. Now here you see the plane has been corrected. I will show you that the same X-ray, same thing. This was a case. This was a case which was sent. I asked them to correct the plane and send me the OPG after correction of the plane. See, this plane has been kind of straightened down, but it is not. When you follow this plane, I'll just go and show you. When you follow this plane, so this has been corrected for plane has been corrected, plane of camphor has been corrected and was sent to me. Now you see this line. Notice here what has happened. This is like this. Always see to that the 7, that is the second molar, should be above, should be like this, should go like this. Otherwise, if it is like this, what will happen is when you place an implant here, this can come and hit here, and then the anterior protrusive movement can be a big problem. This can cause interferences. So always this should be reduced a bit like this. Not so much, but still more than that. Now see how this plane has been corrected. You see how this is coming in. How this plane is going. See this. So it almost, and this was the first origin, this was the original condition. We have corrected entire plane like this, and then rehabilitated it. Hope you understand the importance of plane of camphor when you are rehabilitating, whether it is implants or whether it is a bridge. This plane of camphor has to be corrected, which I have seen in many cases, whichever I have seen, many cases they don't follow this plane of camphor. Now, coming on to the target areas in OPG. Our main target area is, you all know that most of the times maxillary is tough to crack. Basically because the distalmost maxillary bone is very, very soft. So you have only, I hope this can be understood by you. This is the medial pterygoid, and this is the lateral pterygoid, and this is the medial pterygoid plane. And this area will be our target area. Okay, so the zygomatic bone is another area, but we will not be discussing about zygomatic bone because that comes from complex surgeries. And the next is the zygomatic bone. Next target area in for maxillary. See, basically what I would tell you is, why do we select these target areas? These target areas are the highly mineralized or highly corticalized bone in the maxilla. Why do you want? You people always say basal implants, cortical basal implants is a failure. You know why this is failure? Because people do not follow all these protocols. That is the reason why it fails. If it is done properly, it will not fail. There are a lot of things to be taught as far as occlusion is concerned. If you don't follow this protocol, just imagine in a conventional implant, you place the implants in an alveolar bone, whereas we place it in a cortical bone, which is far away from the tooth, from the tooth. So just by logics, just by common sense, you should understand that there is lot of distance travel. So naturally, the surface area bone to implant contact is more. So which has got more likely chances of failure, whether when you have more amount of implant to bone contact or when you have less amount of bone to implant contact as in the conventional implants. It holds logic that the chances of failure is less when you have more amount of implant to bone contact. That is one thing. The second thing is, wherever you place, our protocol is to place these implants in a highly mineralized bone. Why highly mineralized bone? There are two reasons why we place it in highly mineralized bone. One is, in a highly mineralized bone, the load distribution is much better. That is one thing. The second thing is, bone remodeling is very less when you are placing it in a highly corticalized, highly mineralized bone. Definitely it has got a disadvantage. One major disadvantage is the blood supply is very less. And if you try to compress it more, chances of failure is very much high as far as corticalized bone is concerned. So, and anyway, you understand that by logics itself, there are people who says that, oh, this can fail. Why? Because I'll tell you, there are two reasons why people might say that this fails. One is fear of death. That is one thing. People might fear, doctors fear of death, and because of that, they restrain themselves from placing these implants. Second thing is, they are not afraid of the death, but they come across failure because of lack of knowledge regarding simple things. Plane of camphor correction before you place implants, correcting the plane of camphor or plane of occlusion before placing implants. Then no cantilevering at all. when occlusion comes in. That is very, very important. I will be talking about the occlusion later on in the third or fourth webinar. Then you will understand. Now, talking about psychopathic bone, that does not come out under our purview in this case, this session. Floor of the maxillary sinus, not a very good bone, but still can be relied on. Sinus septal bone is far better than floor of the maxillary sinus. Then bone between the sinus wall and the palatal bone. Inverted O line of Ennis, nasal floor and anterior nasal spine. These are the areas where we target as far as maxillary is concerned. I'll just go in detail about all these things. Now, when we think lateral and medial pterygoid, you might feel that, oof, this is an area which is dangerous. I will tell you this is very, very safe. Why? Because there are absolutely no blood vessels and nerves. That's one thing. All muscle attachments are in the lateral pterygoid plate. There is no muscle attachment in the medial pterygoid plate at all. So the junction between the lateral pterygoid and medial pterygoid is considered very, very safe, provided you can consistently reach that area. And I have developed a technique where it is very, very easy to replicate reaching the lateral and medial pterygoid without any tension.
In case of pterygoid implant placement, we have to know where it has to be placed properly. In this slide, we can see this is the lateral pterygoid plate and this is the medial pterygoid plate. Pterygoid implants are directed from the tuberosity region, then angles backward, engaging the pterygoid process of the sphenoid bone, which is a safe area where no blood vessels are found and all the muscles are attached to the lateral pterygoid plate.
So basically, I'll just show you once again. So basically, I'll tell you one more thing. This area is where you have this is the pterygomaxillary.
Placed properly. In this slide, we can see this is
So this area. Let's go back one second. This is the area which is just can you just pause it? So I'll just tell you that this is the area which has got all this. This area is the area where you have all this. This is pterygomaxillary fissure area where you have all maxillary artery, all this pterygoid plexus. All the. I'll just show you once again so that you will understand that. So this area is where this is the pterygomaxillary fissure area, posterior to the tuberosity region, where you have the pterygoid plexus, you have inferior, you have the maxillary artery, all those vital structures there. And this is the distance from here till here. That is from the tuberosity to the pterygomaxillary fissure is almost 35-40 millimeters. So the longest drill is 30 millimeters. So there is no chance of you getting into this pterygomaxillary area. So that is why we will say that it is very safe. Now I'll just show you how to identify this pterygoid plate. You can see a wing-like thing here. Can you see a wing-like thing here? Yes or no? Can you see this? Please answer yes or no. Okay. Now this is the. I'll I'll tell you, this is the tuberosity. This is the wing. This is the wing. So your plan is from here getting to this. This is very clear, I believe. Now you see in this is the wing. Your plan is from here you should go and enter here. I hope this is very clear. Because see, because this pterygoid plate has got good amount of mineralization. All this area, the maxillary tuberosity area, has got very soft bone. So it will not hold on to the implants and you will not get sufficient torque to angle it there. Now see, this is the CBCT session. This is the coronal session. You can see how this is. So this is the lateral wing, this is the middle wing, this is the lateral wing, and our target area will be this one. This is our target area. There is nothing here, nothing, no structure. This is just loose connective tissue which is present here, and you have muscle attachments only on this bone. So if you target this area, you know what I do? I keep my fingers here. This portion, left index finger here, so that I can palpate and then find out, and then target I keep my fingers here, left index finger here, and then I target. I don't drill in that area. I just tap the drill, and then I reach there. I feel it, and then I replace it with implants. Now see here. This is a sagittal session of the. I'll just talk to you in detail when the other people comes to the training program how to read the CBCT. This is a sagittal session similar to that OPG what you see. Now this is the plate. This is the tuberosity. And your target will be like this. You will be going like this. I hope this is clear, but I'll teach you, all the people who have joined for the training program, I'll teach you how to go through the CBCT by going through the DICOM file and RAR file, so that you yourself will be able to, not depending upon the depending upon the scan center, you yourself will be able to read through your CBCT and decide on. Probably this can be used for your endodontic treatment also, instead of relying on the scan. I do not believe in scan centers. Why? Because you are the clinician. You know where you want to go, but they will not be able to tell you where exactly to go. So it's always prudent that we learn rather than we being advised where to go, because you know you are the clinician. Now see, this is a case where when I was going, see this, I told you, when I work, sometimes I take an IOPA just to reconfirm whether you are going in the right direction. The implant was placed, was not placed. During the implant placement, I got some resistance. So I just wanted to confirm whether my implant has reached the pterygoid plate. So occasionally, especially in the case of pterygoid area, when I place, I try to take an IOPA to reconfirm whether I am going in the right direction. If you are an expert person, you don't need to, but I always prefer to err in the side of caution. So now see, I'll just draw you. This is the wing. This is the plate, pterygoid plate. You can see this is the pterygoid plate. Now, if I travel 2 more rounds, I'll reach here. So that will be my target area. This was taken just before, just to reconfirm, because I was getting a lot of resistance, a lot of torque when I was placing these implants. So I just wanted to confirm whether I have reached already the pterygoid plate. Hope this is very clear. So it's very safe. You place it. This is just tapping through. I don't even drill. What I do is I just tap the pilot drill from here till here, and after that I just take an X-ray, confirm that I have reached. I'll be keeping my fingers here. From the tuberosity, I'll be keeping my fingers like this. So I can really feel the drill or the tap coming here. And according to with the fingers, I'll guide my implants as well as the drill. So this, I'll be showing you during my training program how I do it. So it'll be very easy for you to, practice in your clinic. See how these implants are being placed. You can see This is the lateral pterygoid. Sorry, this is the middle pterygoid. This is the lateral pterygoid. And how the implants is penetrated. This is a CBCT section. How these implants is penetrated the lateral and the middle pterygoid. Now, floor of the sinus and maxillary septum. You should know. You know what is this line? Anyone to say what is this line? This white line. This white line is a palatal bone. This is the floor of the maxillary sinus. Not a very good bone for anchoring, but still, at times it helps. But this septal bone, which you see, this is a real good bone compared to this floor of the maxillary sinus. This is a better bone. You can see the opacity of it. See, this is another area. You can utilize these areas for placing of implants, provided it should be wider, little more mesodistally. Always buccolingually there will be width. Always buccolingually there will be width for the nasal septum, maxillary sinus septum. But mesodistally sometimes the width can be less. But you can confirm it from OPG or by CBCT, preferably CBCT, before you decide whether you are taking maxillary septum as the target area. Now, the next space which I do is, see, this is the nasal floor, this is the nose, nasal cavity, this is the nasal cavity. Can you make out? This is the nasal cavity. This is the floor of the nose. This is the palatine bone. This is the maxillary, lower floor of the maxillary sinus. This is the anterior wall of the sinus. Now you can see that this space between the maxillary sinus, this one, and the palatal bone, you have a area. You can see how I have gone between that. If you see the IOPA, you will feel that the sinus is dipping somewhere here. But you can see that some area it is dipping like this. But you can utilize this space and go and engage like this between the. But when you see the IOPA, once the rays are taken like this, you will feel that you have penetrated the sinus. It is not so. It is actually the space bone between the maxillary, the floor of the maxillary sinus and the palatal bone. So, I'll tell you when we come on, I'll just tell you now how I do this. See, you can keep your fingers on the palatal, on left fingers on the palatal side, like this. Okay. Now, you can plan to start your drilling around 3 or 4 millimeters from your finger. That is, just take 3 millimeters from here. Now, this will be the position where you start drilling. And your fingers will be always here. Your fingers will be kept here. If you drill parallel to your fingers like this, you will reach the nasal floor. I hope this is very clear. This is my technique. How I do that. Exactly, you will not go to this side, you will not go to this side, you will be exactly in the middle. There is no question of error in when you do this. But planning is very important. Now, Y line of N is, see, this is the maxillary sinus. Okay, this is the lateral wall of the nose. This is the lateral wall of the nose. This is the floor of the nose. This area is highly mineralized. This area is a very good area for placement of implants because it is highly mineralized. Same way here. Okay. Now the nasal floor penetration. You can see this is the nasal floor. All these implants are penetrated. You might think that you have penetrated into the nasal floor. What happens is, when you place these implants into the nasal floor, what happens is, the mucoperiosteum gets lifted. This mucoperiosteum gets lifted like this. And bone will form underneath this. So there will be bone formation underneath. So this is the CBCT session of the nasal floor penetration. What nasal floor penetration? You can see this implant is penetrating into the nasal floor. What happens is after a few months, if you take, you can see there will be bone formation around this, like this. Anterior nasal spine. That is also a good area for placement of implants. Only thing is that there will be nasopalatal duct which comes at the behind, but you have ample space in the front, in the anterior region. So there is no question of penetrating into the nasopalatal duct. So this is the thing. So you can see a dark radiolucency here, This is actually the nasopalatal foramen, this area. You can see a highly mineralized area. This is a wonderful area for anchoring the implants. And thank you. And now it's open for, can you just unmute? Yeah. Yeah. Hello doctors. You can come up with questions. Can you hear me? Now, now you can speak.
Speech material.
Do you want me to go back to the slides? Do you want, yeah, can you just go back to the slides? Hello Manu, Dr. Manu. So let me draw you from the OPG. You should be able to find out the pterygoid area. If you see this area, now see this is the tuberosity. Is this clear? This is the tuberosity. Is it clear? Now this is the wing. This is the wing. And this area has got a lot of medullary bone which is very, very soft, which is not good for anchorage, but this area is very highly mineralized and you can place implants like this. Is it very clear now? Now, next session, this will be my target area. This is the lateral wing of the pterygoid plate. This is the medial wing of the pterygoid plate. You have loose connective tissue. All these areas you have loose connective tissue, and muscle attachment is only in this area, in this lateral pterygoid. This lateral pterygoid has got all the muscle attachments, and medial pterygoid has nothing. And you have loose tissues here. So this area is very safe. This is the coronal section. This is the sagittal section. Similar to the OPG, you can see this is the outline of the tuberosity region, and this is the sagittal section of the pterygoid plate. This is the pterygoid plate. This one. Is it clear now? Here in the IOPA, this is the pterygoid plate. Anyway, when participants come down for the program, I will show you how to take this exercise while you are operating. And what I do is, I keep my fingers, index finger or any finger, in this area like this, so that I can feel the junction. I keep my fingers like this. I can feel the junction of the lateral and the medial pterygoid, and then I keep my fingers there and then start tapping the drill into this area. So I can really feel that area. And I will be placing it parallel to my finger. I will be tapping it. See, this is my finger, and I will be placing it parallel. I will be tapping the implants or placing the implants parallel to my fingers. So there is no chance of it going other side or this side. It will always go directly to this area. I hope this is very clear. Yeah. Any other questions? Any other questions? How did you feel this webinar? Was it useful to you? Because yeah, thank you. Actually, you can actually use this whatever I have talked, like plane of camphor and all those things. Yeah, you want to go through all the slides again? Just a brief. Yeah, I'll do that. I'll just brief once again. I'll just go through all the slides once again and then explain to you so that it will be easy for you to understand. Yeah, sorry, please go through the slides again. So I'll just go through it once again. So the basic sequence of events will be clinical examination. But nowadays, even before the clinical examination, you get to see the patient's OPG because most of the people are traveling from from abroad or far other places. So they send you the OPG and then we have to assess, give them a treatment plan prior to them coming down as well as the financials. After that, I'll decide on where all I have to place the implants, my target areas, and check whether these areas are suitable by using a CBCT. That's the second step. Once from OPG, I take a CBCT. Then I go for the treatment planning. During the treatment planning, as I've shown you earlier, I might take an IOPA and CBCT if required. And post-implant placement, I go for OPG and CBCT again to reconfirm everything is perfectly fine. And after that, I place the crown and bridge in after 3 or 4 days. And then I do occlusal correction and follow. This is the normal protocol which I do. Now, as you know that OPG is not very specific. You need sometimes to take specific IOPAs to confirm the prognosis of the tooth. Now, let me tell you this is a case which we discussed earlier, where upper is definitely a full mouth case, lower can be a segmental or can be a full mouth case. The lower one you have to discuss with the patient whether they have to go for a full mouth or there are advantages and disadvantages. Advantage if you go for a full mouth is that there will be cross arch stabilization. Cross arch stabilization in the sense, cross arch stabilization in sense you have implants like this, three implants if you want to place a segmental one, 3 implants like this, if you want to place a segmental one, and then you will connect it together. So this will be the segmental one. But if you remove all these teeth, you need to just place 2 more implants like this and connect it as an entire thing. So this gives a cross arch stabilization of all the implants. And you understand? So the advantage is if you go plan for full mouth, with the addition of just 2 implants, you will be able to give a cross arch stabilization. But the disadvantage is that sometimes patient might psychologically feel that they want some few teeth to be remaining, which is actually illogical. I hope this aspect is very clear. Now similarly, these two teeth has a very bad prognosis, so bridge was not planned and implants were planned in this. Now you can see how these implants, see this, in this, these two were removed and then these implants were placed like this. You can see there is a bypass of premolar to the lateral wall of the nose. This area was bypassed. Now here this was a full mouth, upper full mouth, and lower this area had very bad prognosis. So hence the upper was full mouth applied and the lower, this was the one which was placed. And this is the same thing which I have talked about. Now here in this case, generally the wisdom tooth has to be taken out, but I have not taken out in this case. This was upper full mouth and lower I had placed two implants here and then rehabilitated. Always see to that the bite is symmetrical. See here, the bite is symmetrical. Occlusal plane is symmetrical from here till here. If you have a larger occlusal plane, chances of patient biting on this side will be more, resulting in overload osteolysis, destruction of the bone. Now considering the plane of occlusion, as I have told you, this is the plane. So different areas. You have the tragus till the L of the nose. This line should be parallel to the occlusal plane. So you should plan your treatments in segmental cases. Even for the bridge as well as implants, in segmental cases, you have to plan such a way that the occlusal plane is always parallel to the L tragus line. So sometimes the L tragus line can be, the tragus, it can be from here till here. Sorry, this is not straight line. It can be from here or it can be from here. This depends upon the length of the ramus. It varies from person to person. Oh, now here in this was this case was rehabilitated, plane of correction was done like this. I had advised to cut this out, cut this down, because if you see this will be the L tragus line.
Prosthetic principle remains the same.
Pardon?
Prosthetic principle.
Yeah, prosthetic principles remains the same for implants as well as the same. But more often than not, I've seen many bridges being placed without correcting this plane of camphor. Prosthetics remains the same. Now see here what has happened. This was actually, because of supraeruption, this was placed like this. And I had corrected all the plane in accordance with the L tragus line, that is plane of camphor, and then rehabilitated. Now as far as the target areas is concerned, now the junction, as I have told you, junction of the medial and lateral pterygoid area, it's a safe area, there is no blood vessels, all muscle attached from the lateral pterygoid plane.
So there it has to be placed properly. In the skull, we can see this is the lateral pterygoid plate and this is the medial pterygoid plate. Pterygoid implants are directed from the tuberosity region, then angles backward, engaging the pterygoid process of the sphenoid bone, which is a safe area where no blood vessels are found and all the muscles are attached to the lateral pterygoid plate.
So this I have shown you. This is how the lateral pterygoid plate is. This is the coronal section of CBCT section. This is the sagittal section. This is on the process of placement. I just wanted to reconfirm whether I am directing this into this area. This is the junction of the lateral and medial pterygoid. And this is where how I have gone and placed my pterygoids in between. This is the lateral pterygoid, this is the medial pterygoid. This is how it has gone inside, penetrated the pterygoid plate. This is a palatal bone. I don't believe much in maxillary sinus floor, but I believe in septum. But the problem with the septum is, septums are very rarely you can find the mesiodistal width good enough. Always the buccal width is good enough, but mesiodistal width is not good enough. Sometimes occasionally you find good mesiodistal width. Here you can see this is the septum, but here the mesiodistal width is not good enough to place implants. But I'll tell you, this is a very good highly corticalized mineralized bone compared to the maxillary sinus floor. Now this is an area which is always of my favorite. You can see this is the maxillary sinus floor. This is the palatal bone. This is the maxillary sinus floor. This is the palatal bone. What I do is I keep my fingers here like this, and then I take a distance almost 3 millimeters from here, and then drill parallel to my fingers. So that is I will reach here, and that is how we have placed this. And Y line of N is you can see this is the anterior wall of the maxillary sinus. This is the floor of the lateral wall of the maxillary sinus. Lateral wall of the maxillary sinus, and this has got highly mineralized bone, which is good enough to anchor your implants. So this is the nasal floor engagements. I'm just going through quickly because somebody has asked me to just brush through once again all the slides. And I will do one thing. I will share you the recording. I will share you the recording in the YouTube. You may go through all these things. This is antinasal spine, and yeah. So can we go back? So I hope everybody is there in that webinar group. So we will share you the link, and you may ask any questions whatsoever. I will be answering you there itself in the WhatsApp group itself. If you have any doubts after you go through the section once again, I'm always there to help you. And yeah, thank you all, and I hope this was very useful for you with regard to everything. So we will conduct the next program. We will conduct the next program at the earliest possible, probably next week, within 5 or 6 days, because I have to complete the program. Because my basic idea was to get. We have few people attending our training program. I wanted them to be acquainted with the science before they come down. So how to think, how to plan is all what was there in my mind. So that when they come, they will not be, they're very good. They will know what they are intended to do, what they plan to. So this was my idea. Then I thought I can just share. Then I thought I can make this as a platform for learning. So probably after the implants, I will come up with for root canals also. Basically, I am an endodontist, so I will come up with webinars, free webinars for root canals also. So maybe you can join this webinar, and if anybody else is interested in taking a webinar, but free of cost, you may put in a message in the group so that we will encourage that one also. Because I would like to have this as a knowledge sharing platform. Okay, thank you all. Thank you for all your time. And I hope this was really useful for you, and it was a value for your time. Okay, thank you.